Can you hear me? Can you hear me? Peptidoglycan is the You're not that early. Shay and Abby, can you guys hear me all right? Can you send a text using the chat function as to whether or not you can hear me? I'm using a wireless microphone. You can hear me, okay? Okay, I'm gonna walk to the other side of the room and talk, and then you tell me if you can hear me, okay? I'm gonna walk. Can you still hear me? Can you still hear me? Can you still hear? Can you still hear me? 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 Did you hear me throughout all that? Yes? Yes, 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 yes. Okay, so you can still hear me. All right. All right then, hopefully you'll still be able to hear me when I walk away from the computer. And hopefully the recording will still pick me up when I walk away from the computer. So here's wishing. Okay, gang, it's time to get started. Does anyone have any questions from any of the materials you were asked to go over? Okay, I caught the first half, but not the second half. So the important part for me, so in general, when you take pharm from me next semester, which you should know about each drug. So if you're doing 3x5 cards, here's what you put on them. Name, not the trade name, generic name. Trade names vary. especially from country to country. So the generic name of the drug, mechanism of activity, how it works, indication, what does that mean? What's that mean? Indication. What the drug is for. What the drug is for. Adverse effects, otherwise known as side effects. And then contraindications. When do you not give it? Some drugs we'll see, perfectly safe during pregnancy. Others are not. So those are the things I want you to know for each drug. And that is very much how the NCLEX will test you. Because if you're taking care of a patient who's on metronidazole, what are you supposed to look for? What vitals do you pay attention to? What other drug interactions do you look for? What do you look for in their blood work? What do you look for in their blood gases? That's the part the NCLEX is really going to test you on. So that's my 3x5 card fit for the drug. How they work, what they're for, what their side effects are, because all drugs have side effects. Even natural ones, whatever the heck that means, all drugs have side effects. All drugs at some concentration are a poison. All. I can't emphasize that enough. All. And what's their contraindications? When you can't give them. That's what I want you to know. And who ate the eraser? Any other questions? Let's see. Morgan, can you give streptomycin to treat an anaerobic infection? Depends on what? Okay, try yes or no. Yes, you can. No, you can't. Okay, why not, Clarissa? Why can't you use streptomycin to treat anaerobic infection? Okay, Clarissa just said the answer. Aminoglycosides can only be used for aerobic organisms. You can't use them to treat anaerobic infections. They only work against aerobic infections because the uptake into the cell is oxygen driven. So now, can you name an aminoglycoside antibiotic? Just one. I actually said it when it. Streptomycin. Say it. Streptomycin. Can you name another one? It's, remember Keanu Reeves' character in Matrix? His name was. Oh, come on. What was his character in The Matrix? You didn't watch that either. And he was called Neo, there you go, neomycin. Can you give me another one? Give me a nice wild guess. Yeah, typically. Who? Vancomycin is a glycopeptide. So we got streptomycin, neomycin. How about gentamicin? So that's the gentlemanly aminoglycoside. That's one you can give orally. That's one with the least side effect. So it's the gentlemanly antibiotic. That's how you remember that one. Can you give me one? Aminoglycoside? We have streptomycin, neomycin, gentamicin. There's one that doesn't end in mycin. It's amikacin, and then one that's specialized for Neisseria is called spectrenomycin. And what do aminoglycosides inhibit? They inhibit cell wall synthesis, they inhibit DNA synthesis, do they inhibit membrane, do they inhibit protein synthesis, do they inhibit, what do they inhibit? Yeah, protein synthesis. Very good, very good, very good. And what's their main side effect? That's one. That's not the one you really need to look for, though, if you're taking care of a patient on an aminoglycoside. The biggest one you're going to look for is kidneys. Nephrotoxicity. The other is ototoxicity. So, how can you quickly assess ototoxicity? You guys been taught those quick little hearing tests you can give to patients. You scratch a tragus and you whisper into the other ear. That's easy to do, right? Could you do that? So before you administer the drug, you give that, you note it, administering it, you do that, they start to lose hearing. What do? You tell the provider right away, they're losing hearing. That's the sort of thing you need to be on top of. Okay, so let's go now to our next set of drugs. These are drugs for urinary tract infections. So there's two drugs here in this category. They are completely unrelated in terms of their structure or in terms of their mode of action, but they're used for uncomplicated cystitis. Uncomplicated cystitis and nothing else. Caitlin, can you tell me what uncomplicated cystitis might look like clinically? Patient comes in with flank pain. Is that uncomplicated cystitis? No. Flank pain is indicative of kidney infection. Yeah, That's not uncomplicated cystitis, is it? So you only give it for bladder infections, simple urinary tract infections. And you have the spectrum of these drugs, and you do see resistance to them, but usually with fosfomycin, you're going to be fine at least. With enterics like E. coli, which cause most urinary tract infections, and then Staph saprophyticus. And then some of the others, if it's Acinetobacter, forget it. Acinetobacter won't be hit by either one of these. Now, nitrofurantoin is very well tolerated. You get side effects in less than 1% of the people who take the drugs. People usually will get upset stomach if they have a side effect to this drug. Others may get some neuropathies, peripheral neuropathies. There's evidence that vitamin B6 can prevent that. So if you have a patient who's malnourished, that might be an issue. There's very rare pulmonary toxicities with acute pulmonary fibrosis, pneumonitis. That's quite rare. And GI upset with both drugs has been reported. If you take them with food, that tends to decrease these effects. That's important because both drugs are given orally. So fosfomycin is an anti-cell wall drug. It inhibits the cell wall synthesis. And it shows you the different biochemical steps here and what have you. The bit I want you to just take home is it inhibits cell wall synthesis. That's the piece I want you to get out of this. And it is taken up by specific transporters in the cell, and it mucks with enzymes involved in cell wall synthesis. Therefore, you don't make a cell wall and the cell dies. The nitrofurans are very different. Nitrofurans are reduced by bacterial flavoproteins. When they're reduced, they get turned into this highly nasty molecule that tears up the DNA, tears up the RNA, tears up the proteins. Bacterial cells turn nitrofurans into these nasty molecules much faster than eukaryotic cells do. Also, the nitrofurans are concentrated in the urine. So they do what they do predominantly in the urine. That's why these drugs are so good for urinary tract infections, because your body very efficiently excretes them into the urine. You get very high concentrations of the drug in the urine. No, okay. You do have natural resistance in Pseudomonas and Proteus species. That's something to be aware of. You can't use these drugs for anything other than urinary tract infections. The concentration of the drug in the tissue just isn't high enough. Also, very important, if you have a gout patient, Audrey, what's gout? And what causes it? Sorry? Yeah, but what's the compound called? Uric acid. Uric acid. Write that down. Uric acid crystals. Uric acid crystals precipitate out predominantly at joints, but they can also cause stones in the kidneys that are very painful and do a lot of damage. So probenecid. Probenecid prevents reabsorption of uric acid, so you get rid of more uric acid. Probenecid interferes with the concentration of nitrofurantoin in the urinary tract. Therefore, this drug is contraindicated if your patient is on probenecid. And probenecid tends to be given in drug combinations. So you won't just see probenecid. You'll see a trade name, but it has probenecid in it. So gout patient gets a bladder infection, keep that in mind. Keep that in mind. Are they on probenecid? If not, you can use this drug. If they are, it's contraindicated because you're setting yourself up for treatment failure. All right, good so far? Yes? Now, you have to have an operating kidney for these drugs to work because the kidney concentrates them in the urine. You don't have good kidneys, they don't work. So, contraindicated in patients with renal dysfunction. Contraindicated in patients with renal dysfunction. Nitrofurantoin comes in two forms. One is taken 4 times a day, the other twice a day. And if your patient has trouble swallowing pills, that's a problem. That's a problem. This drug is not given IV as far as I know. Sorry? Yes, you can. You can. Yeah, doesn't come in an injectable form. Does not come in an injectable form. Phosphomycin does not pellet, so it comes with a powder. Take the powder, mix it with water, milk, juice, whatever, and drink it. That doesn't come as an injectable form either. So again, only for uncomplicated cystitis. If you use it for something other than that, it's a treatment failure waiting to happen. Questions about these two drugs? Typically, very well tolerated, both drugs, typically. Vancomycin, the big one here is clindamycin. Clindamycin is usually used for anaerobic infections, but it's also used for streptococci. It's quite good for that, and it also gets used for malaria in some cases. Some strains of MRSA, methicillin-resistant Staph aureus, are susceptible to clindamycin. It's also used to treat pneumocystis urevecii, formerly called pneumocystis carnii, PCP pneumonia. That's what causes PCP pneumonia. Also used to treat toxoplasma infections. There are some gram-negative aerobes that are inherently resistant to it, and you can't use it to treat Clostridium difficile. And enterococcus will laugh in its face. Doesn't work. This is a protein synthesis inhibitor. It interferes with the formation of new peptide bonds. And there is overlap between the mode of action of this drug and your macrolide antibiotics. So they compete for the same site. So you would not want to give this drug in combination with macrolides for that reason. Their mode of action overlap. Their mode of action overlaps. This drug will tend to really chew up your GI tract. Diarrhea is pretty common. Also, you can get superinfection with Clostridium difficile. This drug has the highest risk of C. diff superinfection. So you must watch for that if a patient's on clindamycin. Some patients also get a rash on this. That rash may often be induced by exposure to sunlight. So tell your patient to wear sunscreen, protect themselves, so on and so forth. There is a screen you can do to see if an organism will be resistant to this drug. It's called a D-test. That's a test you can order on the chart. So you send sample of an abscess, something like that, throat swab, punch biopsy, whatever. You can order a D-test. And that D-test will tell you if this drug will work. Also, this drug will show synergy with beta-lactam antibiotics, because beta-lactam antibiotics attack the cell wall. Now, this might make intuitive sense for this reason. Let's say you've got a drug and you have a suit of armor. Drug has trouble penetrating the suit of armor. What if you can soften the suit of armor? Then the drug can get in, right? And that's how beta-lactams will synergize with clindamycin. You soften the cell wall. You soften the suit of armor. And now the drug can get in and kill protein synthesis. This drug can be given intravenously, but if you give it orally, it shows action, absorption, and distribution to tissues. That's what bioavailability means. It means how well the drug gets absorbed and distributed to peripheral tissues. It's extremely good for necrotizing fasciitis. It's extremely good for toxic shock syndrome. And it's also a second-line agent for the treatment of pneumocystic urovecii pneumonia. If you treat HIV patients, you will see that pneumonia. You see that in immunosuppressed patients. So if any of you do oncology, if any of you do any rheumatology, work with patients who are immunosuppressed, AIDS patients, you will see PCP pneumonias. It's also used to treat malaria, stubborn cases of bacterial vaginitis, and it's also used prophylactically for bacterial endocarditis. If you have a patient with a heart condition already and they're going to have dental work, you can use this drug prophylactically. So someone comes in, you're asking what meds are on. They tell you they just had a new tooth put in, some periodontal work, tooth pulled, something like that. You might see this drug in their list of drugs. Questions about clindamycin? Available orally or intravenously. All right. Streptogramins. This is a two-drug combination. A two-drug combination. This combo was designed to treat very, very, very nasty things that are resistant to everything else. So it's called Sinercid. That's a trade name. Sinercid, it's two drugs put together, quinupristin and dalfopristin. Quinupristin, dalfopristin. And my stupid mnemonic, I'm the king of stupid mnemonics, as you well know. Pristin kind of sounds like pristine. What does pristine mean? It means all pure and nice and clean. So this is the pure, nice and clean group of drugs. They're the pristine group of drugs. And quinupristin. Quinu kind of sounds a little bit like Latin for 5. So there's 5 different bugs that this will treat. And that's how I remember quinupristin. 5. Staph, methicillin sensitive, methicillin resistant, Streptococcus, Enterococcus, Faecium, and vancomycin resistant enterococci as well. Quinupristin, dalfopristin, the combo is called Sinercid. Sinercid. Doesn't work on gram negatives. Just works on those really drug-resistant gram positives. You use this when everything else has failed. So this is your SOS drug. So these two drugs bind very close together on the large ribosomal subunit. And if you use each of these drugs by themselves, you'll get mutations that confer resistance. But those mutations occur in the area next door. So by binding to both sections, even if you have mutations that confer resistance, the other binding site is covered. That's why this drug combination works so well. So it's a protein synthesis inhibitor. A protein synthesis inhibitor. And if you combine the two drugs together, they are bactericidal. They kill the cell. They don't just stop its growth. That's why it's synergistic. You put them together, you get a better result than you could have gotten with either drug by itself. Synercid. Streptogrammins, quinupristin, dalfopristin. This drug combo is not given orally, it's given intravenously, and it has solubility issues, so it can cause phlebitis. Clarissa, what's phlebitis? Boy, it's hard to hear with masks on. Yeah, lead to blockage. Blockage, you're absolutely right. Blockage. So you tend to want to administer this by central line. Do nurses put in central lines? No, usually surgeons do. Usually surgeons do, but I've been told that some nurses are getting trained to do that. So that might be a regulation that's being relaxed. Really? Wow. I'm glad to hear that, because some drugs are best administered that way, and some patients need that. Okay. Common side effects are myalgias, arthralgias. Myalgias, arthralgias. Myalgia means muscle pain. Very good. And arthralgia is joint pain. Very good. Very good. These drugs inhibit enzymes that process other drugs. So there's lots of potential drug interactions with these drugs. Watch their meds and look for drug interactions with these drugs. You may see some. Also, never give this stuff in saline. Never, ever give this stuff in saline, it'll fall out of solution. You give it in D5W. Questions? No? All right. Folate antagonists. Folate antagonists. Do we make our own folate? No, we get it from our diet. Do bacteria make their own folate? Many species do. So, if you inhibit folate synthesis, will it hurt us? No. Will it hurt the bacteria? Yes. So this is a potential target for chemotherapeutics. And the big one here is this combo, another combo, sulfamethoxazole, trimethoprim. These are known colloquially as sulfa drugs. Sulfa drugs, you may know this by the trade name Bactrim. Bactrim. You heard that before, Bactrim? Very commonly used for certain infections. This combo, these are competitive inhibitors of enzymes involved in the synthesis of folate. So sulfamethoxazole inhibits dihydroteroid synthetase, and trimethoprim inhibits dihydrofolate reductase. Do I need you to know that? No. What I do need you to know is they inhibit folic acid synthesis. They inhibit folic acid synthesis. Now, folate is a coenzyme. It's a coenzyme that's particularly important in the synthesis of nucleotides for DNA. Synthesis. So, you inhibit folate, you deplete the pool of nucleotides, and you inhibit DNA synthesis. Because you're inhibiting two enzymes in the pathway, the chances of deriving resistance are much lower. That's why you give a drug combination. And you hit two consecutive enzymes in the synthesis of tetrahydrofolate. The biochemistry is very interesting to me. It's probably not interesting to you. I just put it there so you see we know where these drugs work. I just need you to know they inhibit endogenous folate synthesis in bacteria. That's all I need you to know. My biochem students, I'll make them memorize that. And they'll moan and gripe about it, but they'll do it. You don't need to know that. So, what are these good for? Pretty good for staph, particularly MRSA. Good for Haemophilus influenzae, both typable and untypable. And also good for Listeria, and for pneumocystis and Toxoplasma. And then this one used to be called Pseudomonas maltophila. Now it's called Stenotrophomonas maltophila. Good for some gram-negative rods. Good for Strep pneumoniae. Good for several. Pretty good. Doesn't work with a hoot for Pseudomonas. Enterococcus, say, I don't think so. Doesn't work against Strep pyogenes, and does not work on anaerobes. Does not work on anaerobes. Some people on this combo get a rash, particularly if they get sunburned. So you hand your patient the script. One of the first things you're going to tell them is wear sunscreen. Wear sunscreen. First thing you tell your patient. Also, let's say you have a patient comes in, they have a bladder infection, they go home with a script for Bactrim, they come in 4 days later and they have a rash. What are you going to tell them? Probably the drug. Probably the drug. Give it some time. Also, wear sunscreen. Now, hematologic bone marrow suppression. That tends to only be seen at really high doses. But if your patient has weak bone marrow to begin with, this will be more of a problem. So, are you going to check this? Please speak up. It's with the mask is hard. No, there's an easier way. How about a CBC? Yeah, just do a CBC. Bone density, you got to use radiation and plus, is that really going to tell you about the bone marrow? That's kind of a close, not quite what you're looking for. So CBC will just tell you that. And then the renal issues, this is more an issue if you give the drug intravenously. It's not given intravenously very often because the solubility is poor. So you can get some crystals. That tends to be only the case if you have really high doses. Also, if the kidneys aren't working very well in the first place, or the other place where you'll see this, what if they're taking a lot of ibuprofen while they're taking their Bactrim? Then you might see this. So patient comes in, they're on this, they got flank pain, they got blood in the urine, you start to see some crystals. That might be one question you'll ask them, are you taking NSAID, something like that? Oh, your potassium may go up as well, particularly if they take potassium supplements. These drugs are first line for uncomplicated cystitis in women. Comes in a fixed ratio, 1:5, trimethoprim to sulfamethoxazole. Very, very good bioavailability, especially if it's given orally. If you value your license, don't give this drug with warfarin. It'll cause significantly increased bleeding times. And it's just rarely given intravenously because you have to use so much diluent to give it. It is done. It's not done very often, though. Just not very soluble. Tend to be given by mouth. It comes as a capsule. Can you wouldn't want to give it in liquid. It's sulfur, so it tastes awful and it burns going down. So the patient can't swallow. Doesn't come as a suppository. Can you improvise? Doesn't come as a rectal form, to the best of my knowledge, at least in this country. Boy, if you can't swallow, I'm not sure what you'd, because the capsules are meant to be swallowed. You know, if any of you, some of you are seen this, right? You work at retirement homes, yeah? Some of you, yes? Any of you? No? No? Well, if any of you did, I'd say ask the charge nurse at the place you work what happens if someone's got a uncomplicated bladder infection and they can't swallow. What do you do then? Because it's probably pretty common. Catheters are common. So that sort of thing's probably common. Okay, questions about any or all of that? Oh, break time. Let's take 5, then we'll come back together, talk about tuberculosis. Those of you online, please use this time to type in any questions you might have, if you have any. Okay? So let's take 5. Are we what? Yeah, I'm giving you more. What kind of skims on antibiotics, I thought. And since that's a pretty important part of your training, I decided to expand it. You're getting your money's worth. Okay, everyone, it's time to resume. Treating tuberculosis represents a unique challenge because of the unique cell wall of the members of the Mycobacterium genus of bacteria. So these particular organisms have a very waxy cell wall. As we see here in this picture, you have glycolic acids on the outside. These are branched chain amino acids. Some of these form esters with other fatty acids, and that is the very definition of a wax. So you have waxes plus the glycolic acids themselves. Those then attach to these polymers of arabinogalactan. These are just repeating polymers of the 5-carbon sugar arabinose and the 6-carbon sugar galactose. These then are connected to a proper peptidoglycan layer that then beneath that is the plasma membrane. This cell wall is very hydrophobic, therefore getting drugs inside this cell is a genuine challenge. Think of a turtle and its shell. The turtle has a shell that's very thick, very tough, very hard to penetrate, and the turtle moves very slowly. So these cells grow slowly, but they're very tough. So it's like, are any of you German, any World War II history buffs? Any of you? You're looking at me with glassy eyes as if to say, really? We're nursing students. Do we really care about tanks during World War II? Really? Yeah, okay. Just thought I'd ask, don't be offended. So Panzer tanks during World War II had very, very thick armor and were very tough, very hard to penetrate. But they were maintenance hogs and they weren't very maneuverable in the field. The Sherman tanks made by the US were fast, were easily maintained, but had trouble taking down a Panzer tank. But several of them could because they could outmaneuver the Panzer. So think of the Mycobacterium tuberculosis as a Panzer, not a Sherman, but a Panzer tank. So for years, the first line drug for tuberculosis was rifampin. Now, rifampin is unusual amongst antibiotics. It is a direct inhibitor of RNA polymerase. It's a direct inhibitor of our bacterial RNA polymerase. Not only that, it's a specific inhibitor of RNA polymerase. Bacterial RNA polymerase. So it will inhibit mycobacteria. It will hit some other bacteria, but not so well, usually moderately. Now, there's a problem with rifampin, and it's this. Mutations in the catalytic subunit, in the gene that encodes the catalytic subunit of RNA polymerase, will render the cell resistant to rifampin, and those will occur rather routinely. So rifampin is almost always given in combination with other drugs for that reason. You almost never give rifampin by itself. On the average, rifampin is well tolerated, but rifampin, when you dissolve it, it's bright orange. The tablets even are kind of orangish looking. They're potent inducers of liver enzymes, so you'll get drug interactions, and they turn your secretions orange. So if you're contact lens aware, you'll stain your lenses orange, your sweat will be orange, and you'll stain your clothes. It washes out, but it's disconcerting. Also, it turns your pee orange. And patients can call up and they're in a frenzy. I'm peeing orange! And they're just, I had a former student when I was in California who told me the story. She had a patient who was a social worker who went into a house where somebody had tuberculosis. She got an active case. She had to take rifampin. She was not terribly sick. Then she called up in just a hysteria. My body's disintegrating. My pee is orange. And she said, that's the rifampin. And that social worker felt a lot better after that. Some people have hepatotoxicity that they show. Others get severe gastric distension. Some people are hypersensitive to it, but that's not common. Also, a rash is common, especially if you expose yourself to the sun. During the winter in Michigan, it won't be very common. In California, where you get lots of sun, pretty common. Now, here's the kicker. If you have an AIDS patient with tuberculosis and they're on a cocktail that contains rifampin, that's going to interact with a lot of their anti-HIV. So there are clinicians who are experts at treating AIDS patients with tuberculosis. So you have to make sure that you refer them to these people, because coordinating those two meds can be very difficult. 2, never, ever, ever give rifampin as a monotherapy, never. Now, rifaximin is a formulation of rifampin that's not absorbed. And it's used prophylactically if you're going to a country where traveler's diarrhea is a problem. You can take this prophylactically. It'll just go straight through you, and it'll prevent you from anything you introduce into your system. And it messes with your normal flora too, but you won't get traveler's diarrhea. Rifapentin is a relative of rifampin. It's second line. You don't take it daily, you take it once weekly. So rifampin is a drug of choice for tuberculosis or your so-called MAC, that's your Mycobacterium avium complex. So your atypical tuberculosis, another formulation called rifabutin, which is a chemical derivative of rifampin. That is a drug of choice. That's effective against MAC. Rifampin's not very effective against MAC. Okay, questions about rifampin? Isoniazid. Isoniazid. virtually all standard cocktails for tuberculosis will include isoniazid. This drug prevents the synthesis of mycolic acids. So it is a tuberculosis specialty drug. It binds to the enzyme involved with mycolic acid synthesis and completely gums it up. It's like putting chewing gum in a lock so the key can't get to it. And blah, 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 and the punchline is it inhibits mycolic acid synthesis. Do other bacteria have mycolic acids? No. So will this work on other bacteria? No. It's a specialty drug for tuberculosis, isoniazid. But it is the mainstay of many anti-tuberculosis cocktails. Now, this drug has to be given for months. So adverse effects are going to be usually seen much more commonly with this drug because you have to give it for so long. Big E, peripheral neuropathy. Now, research has shown that the reason for this is that the drug interferes with pyridoxal phosphate use. And if you give pyridoxal phosphate supplements, you can mitigate peripheral neuropathy caused by isoniazid. So, you have tuberculosis patients, and they are on a cocktail with isoniazid. Highly recommend vitamin B6 supplementation. Morgan, what tests can you give to a patient to assess peripheral neuropathy? Yeah. You can just take, you can just, do you feel this? Can you feel that? You can do the tuning fork thing, what have you. Those are all very, very easy tests that you can do. They don't take long. Optic neuritis has been reported, not terribly common. You tend to see it in people whose optic nerves are already shot. Seizures have been reported, but they're rare. I think with seizures, ascertain if your patient is a seizure risk in the first place, because those are the people more prone to get seizures on it. And how do you do it? A medical history. We'll cover a multitude of sins. There's reports of drug-induced cases of lupus. These will go away once the drug is stopped, and they're not common. Finally, hypersensitivity to the drug has been reported. It's not common, but it does occur. Tends to occur in people who've had the drug before. First-time drug hypersensitivity is very uncommon. This is the only drug that hits latent tuberculosis. Tuberculosis is active in a latent phase. Most of your drugs for tuberculosis kill growing tuberculosis, active tuberculosis. They don't help with latent tuberculosis. This drug does. Now, there is an acetylated form of isoniazid that is toxic to your liver. Some people have a genetic polymorphism that causes them to acetylate the drug faster. So for these people who are fast acetylators, the drug will be more toxic. There are genetic screens for fast acetylators. They're not commonly used. They're expensive too. Best way to ascertain this probably would be to ask this question. Has anyone else in your family had a problem with this drug? Had liver issues with this drug? The answer is yes. You may want to order that test. Also, make sure that test is covered by insurance. Is getting some pay for that is a hefty chunk of change. I don't think Medicare pays for it. I'd have to check that. I don't keep up with that sort of thing very well, but that'd be something that really to look at. Patients must not drink alcohol while they're on this drug, period. Period. You'll kill your liver. So that means 6 months off the side. Oh, that's not fair. Who told you life is fair? Who told you life is fair? Last time I checked, life's not fair. Who told you life is fair? Whoever told you life is fair was poorly informed. Blood test, and then it's sent to a gene center. Yeah, you don't have to take a piece of liver or something like that, like the old. No, it's a genetic test. Oh, the hepatic panel is done with a blood test. That's for enzymes. This is, you're looking for genes. Okay. Questions? Pyrazinamide. Pyrazinamide only works on growing mycobacteria. How this drug works is still not completely clear. Seems to inhibit fatty acid synthesis. And it does show some hepatotoxicity that is dose dependent. Does cause hyperuricemia if your patient has gout. That's of concern. Causes arthralgias, but only sometimes. So those are 3 things to really watch in patients with those who are on this drug. Only good for the initial phase of active tuberculosis. Once the active phase has been treated, there's no need to keep them on it. If you give it with rifampin, the hepatitis risk goes up. So you don't give it with rifampin. And it works best in an acid environment, so it works inside the vagal lysosome that the mycobacterium find themselves in. Questions? No? Perfectly clear? Okay. FM-butol. FM-butol inhibits the synthesis of arabinogalactan. Does this appear in other bacteria? Arabinogalactan? No. So this drug is a specialty drug for tuberculosis. This is a very effective drug against Mycobacterium tuberculosis, another mycobacterium. It is generally well tolerated. It does decrease color acuity. That tends to go away. If you get it at all, only a fraction of patients will get this. But because of this, you tend to not use it in children because young children, infants, for example, hey, honey, can you see this blue here? Gaga goo goo. Right. Can you see that? No, they can't tell you. So you can't assess color acuity in them. You don't know if neuritis is an issue, so you don't give it to really young children for that reason. Now there is a group of mycobacteria that are called extremely drug-resistant mycobacteria. XDRMT, extremely drug-resistant Mycobacterium tuberculosis. There are some new drugs that are used to treat those XDR strains. This is one of them. This is a very new drug, Vitaminid. It was developed by the TB Alliance. How it works is a bit of a mystery. Seems to inhibit glycolic acid biosynthesis, but evidence for that still needs to be nailed down. Sold under the trade name Deltiba. And it's part of the cocktail for XRD. The other drug given with Vitaminid is this drug, Delmanid. Oh, wait. Oops, sorry. Delmanid is a trade name. Deltiba is a related drug. Delmanid will cause usually headaches in about 5–7% of patients. Dizziness and nausea in less than 10%, but still a significant percentage of patients. QT prolongation has been observed. Clinical significance of it, unclear. So if you have a patient with arrhythmias in the first place, these will need to be watched. And it's metabolized by a significant cytochrome P450. So watch drug interactions with this drug. Bedaquiline. Bedaquiline is the other member of this cocktail with Vitaminid. It inhibits the mycobacterial ATPase. And so it's used with moxifloxacin, pyrazinamide, Vitaminid, and then this drug. That's your combo for the extreme drug-resistant Mycobacterium tuberculosis. Commonly will tend to cause some joint pain that goes away after the drug is withdrawn. Some headaches, some chest pain. Chest pain tends to come and go. Some nausea. Taking it with food will tend to mitigate that. There are serious side effects. They're not common, but you get QT prolongation and some liver dysfunction. So as noted, from our very insightful young lady in the back, do watch your liver panels. You want to be ordering liver panels on a regular basis. Contraindicated during pregnancy. Also, don't give it in combination with drugs that prolong QT interval. Contraindicated in patients who take strong cytochrome P453A4 inducers or inhibitors. Those are two contraindications for it. That is it for the antibacterial drugs. Are there any questions on any of the antibacterial drugs that have been discussed? Yeah, as you guys study these, mull them over, questions may arise. If you have any, please feel free to ask. I realize this will take some thinking, some digestion. You have to take this in small bites and chew very, very well. It's a lot of information. I appreciate that. All right, antifungal drugs. You ready? Your stunned silence truly inspires me. Now, fungi are eukaryotes, but we have some targets that we can consider when it comes to fungal cells. First of all, fungi have a cell wall. Do our cells have cell walls? No, they don't. So, fungal cell wall is a potential drug target. Secondly, while we use cholesterol for our membranes to increase their stiffness, fungi do not use cholesterol, they use ergosterol. Ergosterol synthesis, therefore, is a potential drug target for fungi. Also, microtubules. Even though we have microtubules, fungal microtubules are slightly different. Therefore, there are drugs that can be used to inhibit microtubule assembly. Then there are drugs for DNA RNA synthesis because some of the drugs that can inhibit these will be taken up by fungal cells, but not by our cells. So that's a potential target as well. So first, let's look at the polyenes. Polyenes. The polyenes bind ergosterol, form a complex with it that forms a pore in the membrane. The membrane starts to leak and they'll dies because it's got this big gaping hole in its membrane. These are the polyenes. Now, these drugs have a preference for ergosterol. That preference, however, is not exclusive. They can also bind cholesterol and do the same thing. So these drugs tend to have respectable toxicities. The big drug in this group is amphotericin B. Amphotericin B. B like in Barnum and Bailey Circus. The other drug is nystatin. Nystatin is only used topically. Only used topically. All right? Only on your skin. Amphotericin B is notable for its nephrotoxicity. So to attenuate the nephrotoxicity, people have found ways of delivering it that are less toxic to the kidney. So one very enterprising group made these little liposomes of amphotericin B. They surround it with a little membrane. So they're given in these little membranes. These then roll through your body. They hit the fungal cell and they get dispersed into the fungal cell. They bounce off the kidney cell quite nicely. They have therefore diminished nephrotoxicity. There's also a colloidal dispersion that is not as toxic to the kidney. And then there's the liposomal form, which also does the little membranes. So this binds to ergosterol in the fungal membrane, causes a pore, causes leakage and cell death. This drug is only given intravenously. Very commonly, when you give it intravenously, you get an infusion reaction. The patient is going to feel very cold when it goes in. So what do you have at the ready? Being a good nurse, you have a blanket. You have a blanket. And the second they say cold, you throw that on them, and you're their best buddy. Sometimes it's the little things that's for good nursing, doesn't it? Those little things can really add up to really superior patient care. And they're not expensive sometimes, like doing hearing tests, doing peripheral neuropathy tests, like throwing a blanket over somebody. Sometimes it's the little things. And notice that it comes from medical knowledge, but that medical knowledge leads to a greater application of compassion. Being compassionate is not enough. You can be compassionate and kill somebody if you don't know the right thing to do, right? So the combination of the two really makes for good nursing. Okay, enough of my sermon. What's this good for? It's very good for species of dimorphic fungi. Those are fungi that change their form when you inhale them. Most species of Candida. And most of your molds, kind of good for some of your zygomycetes, terrible for Candida lusitaniae or for Aspergillus terreus. These will only infect very heavily immunosuppressed patients. So with this one, I want you to take a big arrow and put a big arrow next to renal, or take your highlighter and highlight renal. You really need to watch kidney function with this stuff. It's hard on the kidneys. Secondly, infusion-related reactions. You can pre-medicate with Tylenol, acetaminophen, or with hydrocortisone, and completely prevent this. Also, many patients will get rashes, and also your liver enzymes will increase. Now, if you sodium load, you can attenuate nephrotoxicity. So you can sodium load in preparation for amphotericin B administration. Nystatin comes as a cream or as a gel and is used for skin infections, usually candidal skin infections. This is the drug of choice for meningitis, for fungal meningitis. It's the best drug for fungal meningitis. It's given intercisternally in cases like that, right into the CSF. It's a very powerful antifungal, very powerful. But it's not a drug you want to give lightly. It's toxic. Oh, this says I have 2 minutes. Okay, we'll just do 5-fluorocytosine very quickly. This is a antimetabolite. It will prevent synthesis of DNA and RNA. It's metabolized and taken up well by fungal cells, metabolized and taken up poorly by our cells. You always use this drug in combination with other drugs because mutations that render you resistant to it are more common. It's used in combination with amphotericin B. Good for Candida species, Cryptococcus neoformans. Not very good for molds or Candida krusei. And you get bone marrow suppression. That's the biggie with it. GI complaints are common, but they're not very severe. Always check CBCs to determine toxicity. Don't use it as a monotherapy with Candida. And is very commonly used in combination with amphotericin B. And that takes us to the azoles. We will cover the azoles on Friday. Okay, good work, everyone. I'll see at least some of you in lab on Wednesday. Those of you who are quarantined, maybe we could get you to have buddies of yours who could do some of your plates for you. And if you bribe them with chocolate or something like that, that may help. I hope you guys do stay well. The rest of you, please don't get sick. Please, please, pretty please. So, okay, blessings everyone. I will see you then on Friday.